Go ahead and get started. So good afternoon, everyone. Thanks for joining. My name is Demery Henderson. I'm the Grants and Programs Manager here at Civitas. Excited for you all to be here. Now to the next slide. Just have a couple housekeeping reminders with today's presentation on operationalizing data usability and trust at scale. So I just wanted to review some housekeeping. This is a Zoom webinar, so you've all been automatically muted and your video is not displayed. You can feel free to use the chat feature to introduce yourself if you would like to ask a question, or you can use the Q&A function on the taskbar and chat it in there. But this webinar is being recorded and it's going to be shared after today's event, just in the event that someone registered and they weren't able to join. But if you have any questions, feel free to reach out to us at contact@civitasforhealth.org. Okay, so we have quite the agenda today. Lots of great happenings with Laura, Nixon, Ryan, Bramble, and Scott Alderman leading the presentation. But I'll just start by sharing a few Civitas updates, and then I will hand it over to our great presenters. And then we will have some time at the end for some questions as well. So quickly, just wanted to share, in case you're not familiar with Civitas Networks for Health, I'll just provide a brief overview of what we do. So we're a nonprofit mission and member-driven organization, really focused on improving health outcomes for all through health improvement and health data exchange. So here you can see our membership is quite diverse and it includes HIEs, we have RICs, quality improvement organizations, among others, all taking data-informed and multi-stakeholder approaches to health improvement. And then at Civitas, we like to think of ourselves as kind of the bridge between data and doing. So plug for our conference coming up. You've probably heard that once or twice, the bridge between data and doing. But our members do such incredible work, and Civitas helps bring that work to the national stage through our program portfolio, as well as great events like this. So really grateful to all of our program partners and members who help us bring the great attention of the work that they're doing. All right, and then just some upcoming events to note. So we have first, the Direct Trust 2025 annual conference is taking place the first week of August 4th through 7th, and that'll be in St. Louis, so be sure to register for that if you haven't already. And then additionally, Civitas will be hosting our 7th installment of the Fire Deep Dive webinar series that has been going on since the 2024 annual conference, and that will be on August 19th with a presentation from Helios. And they are the Public Health Fire Accelerator. So we started this back in December of 2024. Like I mentioned, it came out of the 2024 Civitas Annual Conference. And Dan Vreeman provided a great overview of HL7 and fire. And then we've just been working our way through each of the fire accelerators since then. So if you would like to register for that, we will make sure to drop that link in the chat. And then all past presentation material can also be found on our website. And then on August 20th at noon Eastern, there will be a California Quality Collaborative webinar, Impactful Interventions to Advance Health Equity. So be sure to check that out as well. And then right after that presentation on the 20th, there will be a webinar on TEFCA presented by eHealth Exchange from 1 to 2 Eastern. And then lastly here, to round out August, we have the Alaska Health Information Exchange Summit will be taking place. So lots of great events coming on this summer. And if you'd like to see events beyond the summer, we have a page on our website. So feel free to check that out as well. And then other great upcoming events. Our Civitas annual conference that I've mentioned is taking place at the end of September in Anaheim, California. And we're expecting over 800 attendees this year. So really excited to see our members and colleagues from around the country. I think we just broke almost 500 attendees already registered, if I'm remembering correctly, which is really exciting. So thanks to everyone who's registered so far. Our agenda, registration links, and keynotes can be found on our website. And just wanted to quickly thank InterSystems for being our platinum sponsor again this year. And then thank you to our conference sponsors here. We have upgraded sponsors, CyncHealth, Comagine, Secure Exchange Solutions, Selfie, eHealth Exchange, Sac Valley MedShare, KPI Ninja, MyHin, Innovacor, Point Click Care, Smile Digital Health, Quanta Health, Formedica, and J2 Interactive. And of course, thank you to our silver sponsors as well. The conference would not be possible without all of our amazing sponsors. So thank you so much again to all of them. All right, and the room block for the annual conference is also available. It will be at the Anaheim Marriott, so be sure to take advantage of those discounted rates by September 5th at 5 p.m. Eastern. The room block is going to be available from September 26th to October 2nd. And then just wanted to quickly call attention, we were notified of a phishing attempt that is directed at individuals planning to attend our conference. So please go through the direct link on our website to book your room block. Don't go through any links that come through your email from a hotel. So those are unofficial links. And if you have any questions or hesitancy, please let us know. We're happy to help you out. All right, and then speaking of the conference, be sure to also mark calendars for the virtual pre-conference sessions. So we're going to start generating some excitement leading up to the end of September with our in-person conference in California. And our first session will be on August 12th, Making SDOH Work, Tech Partnerships and Real-World Wins, presented by J2 Interactive. And then there will be pre-conference sessions throughout the rest of August and into mid-September as well. So those are great informative sessions. Be sure to attend those and mark your calendars. And you don't have to be registered for the annual conference to attend these. So be sure to put those on your calendar. And thanks to J2 Interactive for being our pre-conference sponsor. All right. And then as part of the conference, we sell merch each year and select a charity for the proceeds to go to. And this year, the proceeds will be donated to It's Bigger Than Us LA, which is a community-based nonprofit focused on advancing health equity, long-term recovery care, and resource access for underserved families in California. And I do think that this year's merch is some of the best yet, so be sure to check it out. We can all match the conference. We're planning to all wear our shirts on Monday, September 29th to kick off the event. All right. And our Community Excellence Awards, I just wanted to call attention to that. They are now open. So we present these awards at our conference each year. And it's really just a chance for us to celebrate the remarkable individuals and organizations in our community who are making especially positive contributions. So nominations close for that at the end of the month, August 29th. So be sure to nominate a great person or organization you know of before then. And lastly, if you're a Civitas member, we really want your feedback. The annual member satisfaction survey is out now. So we want to hear from you on how we can improve your membership experience and shape the Civitas programming for the rest of the year and into 2026 as well. It's very short. It's just about 5-7 minutes of your time, and multiple responses from organizations are welcome. So feel free to share with others in your internal team. And we're offering some incentives as well for participation who share their contact information with us. So you will be entered to win a free registration to next year's annual conference. And then there will also be 2 $100 Amazon gift cards available as well. So please take the survey. If you have a free moment, we would really appreciate it. This is definitely one of the most important surveys that we put out each year. So if you're going to take one, please take this one. We would really appreciate it. All right, and with that, I will stop and turn it over to the clinical architecture team for their wonderful presentation today. And again, thank you all for joining us.
Thank you so much. And hi, everyone, and welcome. I'm Laura Nixon. I am the VP of Interoperability Solutions at Clinical Architecture. I was just looking at the participant list and I see tons of my friends here. So hi, everyone. Really excited that you're here. And I am really excited about the topic that I'm talking about today. So today's session is designed, and you can go ahead and go to the next slide. So today's session is designed as a mini masterclass on something I believe is really foundational to everything that we do in health data exchange. It's trust, and more specifically, trust in the data itself. And we all know that we've spent more than the last 2 decades building the infrastructure for interoperability. And we know that the pipes are there and the messages are moving. But we also know that if the content that's flowing through those pipes is incomplete or misaligned or unusable, then all of that infrastructure is falling short of its promise. And that is the core challenge that I'm going to unpack with you all today. So here's my plan. Here's our plan. We're going to ground ourselves in why usability, not just transport, is the central challenge of interoperability. And then I'll walk you through the PIQI framework, what it is, how it works, how it helps us move from blind faith in parsed messages to an actual transport model that is built for assessing and actually improving data quality. We're going to take a technical deep dive into the inner workings of the model or of the framework, including the information model, the taxonomy, simple assessment modules, and how the logic gets composed into rubrics. And then we're going to shift into real world application with a cool panel discussion with our friends Ryan Bramble from Chris Shared Services and Scott Alderman from CyncHealth, two newly designated CMS aligned organizations that are thinking very seriously about data usability at scale. And then finally, we'll open it up for your questions and discussion. So don't hesitate to throw questions in the chat or in the question and answer section, and we will get to those. So I really feel like whether you're technical, operational, strategic, you're going to walk away with understanding the PIQI framework and thinking about new ways of trust and transparency and really what it means to have data that's ready for use. So let's get started. We can go ahead and go to the next slide. Just a quick grounding on who clinical architecture is. And I'll make this pretty brief. We were founded in 2007. It's a privately held company based in Carmel, Indiana, and our team spans across the United States and all the way to the UK. We have a leadership team that has experience across all organizations like Metaspan, First Data Bank, MetLife, and the National Library of Medicine. And that deep operational knowledge combined with work in very large health systems gives us a blend of frontline reality and standards leadership that really shape how we think. We don't build tools, we help actually define the rules. So with that foundation, let's go ahead and get into it. We can go ahead and go to the next slide. Because the real challenge is not whether that data showed up, it's whether you can actually use it. So, like I said, we've solved the problem of plumbing. We know that CCDAs are flowing, HL7 messages are parsing, FHIR endpoints are responding, but if we really get into it and we start digging deep and we ask the people who are using that data, like our care coordinators or our public health teams, analytics teams, they all tell us the same thing. The data arrives, but it's not really usable. We have missing values, we have bad codes, we have clinically nonsensical information. We know that it's structurally fine, but operationally it's worthless. And it's very clear that parsing is not the same as usability. So you can pass syntactic validation and then still fail the moment that the data hits a workflow or a report or a dashboard. And that is what we're solving right now, the real frontier. It's not about did we get the data? It's about can we actually use it? And in reality, the only way to answer that question at scale and with confidence is to move from infrastructure that routes messages to an infrastructure that actually evaluates them. And that is where PIQI starts. It gives you a way to assess what's inside the message against real-world expectations in real time and at the level of detail that actually matters. And so that begs the question, what do we do about it? And go ahead and we can move to the next slide. So Charlie Harp, I'm sure you all have heard of our illustrious founder and CEO at Clinical Architecture. He's quite brilliant and saw the gap that I just walked us through. And he said many, many times that parsing a message isn't the same as like what's trusting what's inside of it. And he's told me so many times he was not content to build another tool. He really wanted to actually change the conversation. And that being said, PIQI was built to give us a shared, standards-based way to measure whether the data that we exchange is usable. And it wasn't built in a vacuum. It came from straight from what we have been seeing across the board with health systems, HIEs, payers, public health agencies. They are all struggling with that same disconnect. The data has technically arrived, but nobody was using it with confidence. And that's what sparked the creation of the PIQI Alliance, which is a community that is committed to turning this framework into an infrastructure that we can all stand on. And I put a little quote here from Charlie because I thought it was really relevant. He created PIQI to help the industry stop pretending that parsing equals usable data. He said, I could create a product or I could make a difference. And I wanted to make a difference. So let's go ahead and move on to the next slide and talk about what the PIQI framework actually is and what makes it different from other approaches to data quality. So again, infrastructure is there to move across systems and messages are parsing. We see our interfaces are lighting up green and technically that exchange is successful, but is the data usable? So messages are missing critical values and then codes are invalid or outdated or from the wrong system. And then we're finding fields that are inconsistent or implausible or even blank. And that was what the gap, and that's the gap that PIQI was built to fix. So what is PIQI? PIQI stands for the Patient Information Quality Improvement. It's a standards-based real-time framework that evaluates the usability of clinical data, not just its presence. And that means it does it at the message level as data is flowing, and it's not weeks later through a retrospective dashboard. It's in real time. And the core of PIQI is a canonical information model. You're like, what does that mean? So think of that as a normalized structure, a semantic scaffold that transforms HL7v2 messages or CCDAs or FHIR messages or even flat files into a predictable format. So that structure then becomes the foundation for all scoring. And from there, PIQI applies scoring logic based on the 4 design principles, which are a simplified patient data model, a shared data quality taxonomy, simple assessment modules, and evaluation rubrics. And these are not just features, they're really what make PIQI scalable, explainable, and reliable. And we will go into that next. All right, perfect. Thank you. Great slide change. And you can hit one more time. There you go. Thank you. All right, so let's talk about where data quality measurement really begins because it doesn't start with scoring, it starts with structure. And clinical data shows up in a lot of different ways. We know that. I've mentioned them over and over. HL7v2, CCDA, FHIR, flat files, and all of those, each one of them have their own quirks and they have different segment structures, they have different terminology systems, they have different nesting logics, different levels of consistency. And if we tried to apply quality rules on those native formats, we'd end up with brittle logic that really only works in very narrow circumstances. It wouldn't be scalable and it would not be consistent. So that's why we start here with PIQI. We normalize the messages into what is called the PIQI patient information model, which is what you see here in this diagram. This model serves as a flattened, predictable representation of patient data. So each element, like a lab result or medication diagnosis, is broken down into the attributes that matter for evaluation. So that could be dates or codes, values, whatever is needed to make the determination about the quality of that message. So think of that as semantic foundation. Regardless of what format the message came in, it gets transformed into this model before any scoring happens. And that's what gives us the ability to then apply the same logic across different message types. And once that data is transformed into that structure, we can then run simple assessment modules across them consistently. And that's the point, right? You want to be able to measure quality in a reliable way. And to do that, you have to have a common structure. And you need to know what you're measuring. And then you need to have the structure that's predictable. And then you need to be able to apply consistent logic across all messages in source. And that's what makes it possible. It's not just something that's convenient, it's actually an anchor for the entire framework. So everything starts here as standardizing the structure. So let's go ahead and move to the next slide into the second design principle, which is called the PIQI Health Data Quality Taxonomy. Because once the data is structured, the next challenge is then knowing what's wrong with it and how to talk about it. So that's where this comes in. And we built this taxonomy to classify data quality issues based upon how they impact real world usability and trust. So it's not just vague terms like error or invalid, but these categories are broken into, these categories break the data into things that actually matter and that can be consistently scored on. So we have the first one of availability. Is the data even there? And that's where most of our failures start because the data may be technically present but functionally absent. So like if a patient doesn't have a problem list. The second is accuracy. Is the value meaningful? Not just a valid format, but a usable value. So, for example, if a BMI is like 1200, we know that that's obviously not accurate. Third is conformity. Does it follow expected standards? And that's about structural and semantic consistency. Like using local codes instead of LOINC, or even a wrong code system for a given profile. And then finally, plausibility. Does it make clinical sense? And this is usually where trust either takes root or it collapses, right? So a future birth date or a male patient with a hysterectomy. They're not just technical misses, they're actual failures that erode trust and undermine the entire point of interoperability. So now that we can categorize these issues, let's talk about how the actual checks run. So we can go ahead and move to the next slide. All right, so simple assessment modules are a way to evaluate the content of each message. A SAM, or Simple Assessment Module, is the fundamental unit of evaluation in the framework. It's a microcheck, something that's small and reusable, that asks one very specific question and gives a very clear result, either pass, fail, or could not assess. It's a tiny micro rule, like a yes or no check that evaluates one thing clearly, transparently, and consistently. And that's what makes SAMs so powerful, because some SAMs depend on others, like checking plausibility only after confirming that a unit of measure makes sense. You have to go in order, right? So they stack up like little Lego blocks that build sophisticated logic from really simple, explainable pieces. And if you'll tap your mouse one more time, there's one more graphic that'll show up. So the wheel on the right shows how each of the SAMs map to the PIQI taxonomy. They align to the colors. And that mapping is what turns a SAM result into diagnostic insight. So that way we can actually see what the error is so that we can fix it. And so let's go ahead and move to the next slide, where we see how these get assembled into evaluation rubrics. And so evaluation rubrics are what brings everything together into something actionable, right? We've structured the data into the PIQI model, we've applied the taxonomy, and we've run our SAMs to evaluate the individual attributes. So now the evaluation rubric takes individual SAMs and arranges them into a scoring profile, and one that like reflects what's important to a specific use case or a stakeholder, like evaluating US CDI version 2 versus 3. And maybe a payer organization is prioritizing coding accuracy, or a public health agency is thinking about immunizations or vital statistics. Or we're thinking about onboarding a new data feed, and we're looking at demographic completeness. Do we have race, ethnicity, language, contact information, etc.? And that's the key. All of these different organizations can still use the same SAMs and use the same structured model, but can score differently based on different expectations, because each of these rubrics reflects the needs of the scenario. And that's how PIQI supports transparency, consistency, and reuse without a one-size-fits-all logic and not a black box. So that's really how we operationalize trust, because we can do all of this in real time, at scale, and across any message format. And at that point, you're able to say, okay, is this message usable? And you know, with transparency, traceability, and confidence. So let's go ahead and move to the next slide, where we are going to see this in more of a rolled up look. So this slide kind of brings it all together. Everything we've talked about, the structure, the taxonomy, the SAMs, the rubrics, they all come together in this end-to-end assessment. We call this the PIQI assessment process. And again, it follows a very clear, repeatable sequence. We normalize the message, we apply the evaluation profile, we execute the SAMs, we score the messages, and then we track and trend quality over time. And that's where PIQI really shines, because the scoring is layered. There are 3 levels of scoring, one with each with a different purpose, right? So the first one is our message score. And this is the per message result, which is your baseline. Did this CCDA or HL7 message meet the expectation for usability? Yes or no? and to what degree. Next, we have our entity statistics or SAM statistics, and this is your root cause view. You can see which SAMs are failing most often and why. And are the failures due to like an unpopulated field or invalid codes? And this gives you ability to look at patterns and reasons behind low scores so that you can do root cause fixing. And then finally, we have source statistics. And this lets you look across messages and say, okay, which sources are causing the most problems? And then you can start identifying weak spots by domain. So it doesn't just tell you if something's wrong, it tells you what's wrong, how it failed, and why it matters. And we all know that that's the difference between technical validation and actual true usability. So we can go ahead and move on to the next slide. Thank you so much. So I do want to just quickly ground ourselves in the new evolving CMS expectations that we just learned about yesterday. And I want to do this as we're turning now to what the PIQI results look like as a presentation. The interoperability framework is making things really clear that moving data is not enough. And again, it goes back to that question, is it usable? Not just, is it there? So the PIQI framework is the framework of the data usability. And through the Pixel Gateway, which is Clinical Architecture's commercialized product of the PIQI framework, you can visualize these scores in a way that supports operational trust, and then again goes back to that actionable insight. So we're looking at this dashboard, and you can see that each message is evaluated and presented with clarity. We have usability scores, we have failure breakdowns, we have domain level insights here. And in this specific instance that we have a beta organization, we have over 82,000 inbound messages in 30 days, and only 7% of those were fully usable. And we found nearly 30,000 critical failures. So their average score of 78% for their data usability was not bad, but it's obviously showing that we have some structural issues. So we can go ahead and move on to our next slide. All right, so again, talking about the interoperability framework, organizations are expected now not to just identify problems, but also prove their ability to respond. And so that means we're not just measuring what's wrong, but we actually need to go back and remediate that. So PIQI, the PIQI scoring supports that chain of accountability by pinpointing, okay, again, where are those failures occurring? Why are they occurring? How often are they occurring? And how they trend over time. So we're looking at this dashboard, and in this specific source feed, which you can see up at the top left, it says Beta 01 VA Regional. We had over 761,000 failed records in the conditions domain due to a missing or malformed onset dates. We also found that lab results were routinely failing for lack of required codes or result values, and we didn't have any clean messages in key domains for clinical decision-making or regulatory reporting. So this gives you this proof layer behind every message, which gives you an opportunity to, again, go back to the root cause and make those changes and those fixes. All right, we can go to the next slide. And again, this is another presentation of the PIQI results through the Pixel Gateway. And we are starting to be able to measure readiness, right? Not just are you connected, but are you actually ready to share that data? And so we can start aligning rubrics to standards like USCDI version 2 and version 3 and test and compare your data against future expectations. So in this specific instance, we have two different organizations. We have Regional Health Collective and University Health, and we have them measuring their US CDI version 2 and version 3 conformance. And we can see that the Regional Health Collective is at 72% for version 2, and on version 3, we're at 56. And then the clean messages drop from to 0 under the new rubrics. And we see the same trend at University Health. And so obviously not just a compliance issue, but visibility. Why are we not meeting those US CDI version 3 rubrics in the way that we need to? So it gives you an ability to expose your gaps early. We can even use this to justify funding for remediation. It strengthens your onboarding and shared governance. And then again, instead of thinking, is our data here, we're now moving to, is it usable and trusted? All right, so let's go ahead and move to the next slide. And I want to bring on our friends. As we just talked about the big picture of PIQI and the framework and understanding what's happening in the data and preparing ourselves for what's happening next. And again, to bring it all together, I am here with my friends Ryan of CRISP Shared Services. He is the Vice President and Chief Operating Officer, and he's also the longest serving member of the CRISP team, having joined in 2008. He oversees technology, data security, and implementation across CRISP Shared Services Health Data Utility Infrastructure, which now spans 10 states and territories. And additionally, I have Scott Alderman, who is the Vice President of Business Operations at CyncHealth, the designated health data utility for Nebraska and Western Iowa. Scott's path into healthcare IT began with an 11-year career in the U.S. Army and has grown to decades of leadership across major health systems and exchanges. And at CyncHealth, he's helping connect over 5 million lives across more than 1,100 facilities. And I have some questions I'm going to ask them, and I really just have encouraged them to share their perspective and their insight about what they're doing in the realm of data quality. So, Ryan, I'm going to ask you this question first, and then Scott, you can follow up after Ryan. So, the first question is just very foundational. What made you and your team decide to start focusing on data quality? And when you think about usable data, what does that actually mean to you and CRISP Shared Services?
Yeah, so thanks, Laura, first for inviting me to this discussion on something that never gets old or never gets stale and something that we're always have to be working on. Um, when we started, and I think a lot of HIEs at the beginning started this way, we were very much in the let's just get all the data we can and get to a use case to provide value. And that meant a lot of sloppy data, a lot of bad data, but it did solve a problem that was very prevalent back then, which was just the total lack of interoperability altogether. But as time has gone by, um, we've recognized that there were use cases we just couldn't do because we didn't have link codes or we didn't have the right location the patient was discharged to, or we didn't have the information that's in a note in a discrete format, right? And so we recognized this, and that we had to start measuring what we had so that our partners, our HIE partners, could go out with their outreach teams and determine what data they could capture, that they weren't previously capturing, to improve the quality of data. And that was really, new use cases is really what kind of started it. Some of those are population health reports. Some of those are flagging when preventative services are happening or not happening to support care coordination, and just being able to drive. Um, to be able to tell the story of what's missing so that we know what the problem is that we have to solve. Um, so when we talk about sort of usable data, it really is data that we can use not just at the point of care, but also for care coordination and population health analytics, and really a lot of use cases, and really trying to get to a point where we kind of are future proofed in that the data quality is good enough that subsequent use cases don't require going back to the parsing drawing board and pulling new data elements out of CCDAs or HL7 messages.
Yeah,
Yeah,
great.
I could. Yeah, all the time. I mean, and everything Ryan said is very much in line with much of our same direction, right? And that, but the things that I would add too is being able to one demonstrate, like, there's been so much out there about HIE versus HDU, and really what does that mean, and driving value in the sense that we're not just collecting the data, right? Like ingesting data, much to what like Ryan just said, which is, hey, just give us whatever you got, and we'll bring it in, and then what do you do with it, right? And so we had to really turn and focus more about how that data quality was going to be able to then meet really the environmental demand, like our users, right? Whether it's the public health side, or whether it's the providers, or if it's payers, and making sure that really their investments and being participants within an HIE that is an HDU is really gaining that value out of those return services, right? So we needed to make sure that we improved from that perspective. Otherwise, I think Brian, I think you were alluding to it a little bit, is like you just have a lot of this data that really just becomes a pile of it that you can't really do much with, right? So anyway, yeah, that's really what drove us was again meeting all of those various use cases, meeting the demand from the environment as well as what is being requested from our customers. Yeah.
Yeah, awesome. So that makes me wonder, what are some of the most frequent data quality issues that are coming up that you are seeing? Scott, you can start here, and then Ryan jump in.
Well, it was interesting because as you were going through your demonstration, I mean, your presentation, I'm just sitting there, and I know we was on camera for a little bit and came back off, but there's a many comments that I was smiling about, which is really just lack of, I think, the data gaps, things where we have put in requirements and specifications, and you either don't get them or they come in wrong. LOINC codes, SNOMED, basically a lot of the local codes, the codes that really are required for meeting those quality standards, seem to be the biggest challenge. And as I reflect back on as we've been onboarding lots of customers, is that it's a lot of work for them, right? And so, and the thing is, you would think, well, when you did your EHR implementation, wouldn't that have and should have been maybe part of it? And maybe it was, maybe it wasn't. I mean, I was previously a CIO, implemented an EHR many times, things just become a factor, right, of time. But then when you bring it back and you start really outlining the need for that, well, then the next thing comes around, which is the challenge of questioning. Well, why do we have to do that? We have our EHR, or we've always had it mapped, our way within, some legacy process. But then when you can demonstrate that because it doesn't match the standards or the quality levels, they're not in return going to get what they're looking for out of that information. And a quick just sort of example and story, I won't pick on necessarily the particular area I'm talking about, but after having a couple of these discussions over and over again about the why and really demonstrating why, the quality and what it makes a difference of is, one of the CFOs came back and said, wow, because those codes have now been improved, it's not just, the care side of it, which is highly, which is very, very important, but even now operationally, right? They're seeing a difference in how that data can make an improvement. So.
Yeah, that's awesome. Just again, going back to visualizing what the problem was in order to create actionable insights that make measured differences. So sorry, Ryan, I didn't want to jump on you, but I
No, you're
wanted
good.
to make that. Go ahead.
Yeah, I mean, I think that there's definitely a assumption from places that are kind of outside the day to day that, oh, everything is link coded, links the basics, everything must be link coded, everything must be schematic. We can do all these awesome things with new interoperability methods, fire and bulk fire and all of this new stuff. And the truth is, as Scott was saying, it just isn't. It's just not all link coded. A lot of it isn't still link coded, and you can't necessarily fault the sending systems for doing what they do to get done what they need to get done. They're not thinking about the impact of not sending an interface that's got link coded information on it downstream. They need to be convinced of what's in it for them and all of those things. And it really, really helps to have a framework or guideline where you can measure and demonstrate and show the impact and explain that what this means is that our consolidated view of all the lab data we get from all of our sources across the HIE is going to be missing your data. So I'm going to see the 3 labs that came from the reference lab and another lab that maybe came from a different hospital, but your lab in the middle, which tells a really important story, isn't link coded, so it's not there, and it has an extreme impact on the consumer. And so we're very excited at CSS anyway to see in some of the stuff that came out yesterday, an emphasis on not just the how, but the quality of the data and what's going to be required to make that data interoperable so that you can't just throw a bunch of stuff into a fire endpoint that doesn't mean anything or doesn't have any value. So we see those issues, we see the issues I'm sure everybody sees where, you can get it in the spec, but a lot of it can be blank. Things are named different, there's millions and millions of problems that we have to solve here. And it's really helpful to have frameworks and sets for like, okay, what is the minimum we have to do to at least get everybody to use the same language?
Yeah. Oh, that's absolutely so accurate and so valid in what I think we're seeing across the board. And I think you just opened the door to my next question, which is how do we start deciding what's good enough when onboarding a new source, right? We talked about this early on where we were just like, yeah, we need the data. We'll take whatever you want. And we gave out specifications, but there was maybe some interpretive compliance to said specifications. And so I guess the question is, how do we define what's good enough?
Yeah,
And
I can start. So
yeah,
it is tricky, right? And I'm sure our other HDU and HIE friends on this call know, like there are situations where you can say to a new source, you have to meet this structure, you have to send these things, you must, or you will not be able to send data. But there's also a lot of situations where if you say that, they're not going to do it, and you're not going to get a participant, and your HIE is going to lose its value. And it
yeah,
is a super fine line to toe that, right? And we do not want to put our HIE partners in a situation where they're not going to get any customers because for whatever reason there's political forces against HIEs in that state, and they're not going to get signups. And if we tell them they have to meet a super rigorous data specification, it's just not going to happen. Um, but that said, the value is lost if they don't meet that spec and there's not some sort of fancy new way to improve that data. And who knows if AI will help magically make some of this stuff easier. But we have found that the most effective way to get um, higher quality data faster from sources is not just the ability to demonstrate, to show them what's needed and their compliance with it, and sort of against statewide or national benchmarks. But a lot of times our government partners will incentivize it, right? The Medicaid programs or public health programs will say, well, no, you need to do this so that we can do better e-case reporting or electronic lab reporting. And we saw during like pandemic times when all the first tranche of COVID data came in, was missing all this metadata about the person, and the government went back and said, well, you have to capture this, you have to capture that. And it was painful. But it did kind of make that data much more actionable down the line. So those are really the tools, but I don't think from our standpoint, we're not going to hold it against anybody if they're just not in a position to say, we can't ask for that right now, or we won't get any interoperability at all.
Mm-hmm.
Yeah, it's wow, Ryan, I thought only we had those problems. I didn't realize
No,
that.
everybody's got them. Yeah.
Man, you said it. I'll just add that and reemphasize that I think a lot of really what we've done is demonstrate to them, right? If we can show them, them being the whichever leg of the participant it is, whether it's the public health side or if again it's the providers, payers, that by having this data meet these specifications, because we know we can demonstrate that by receiving that data and that it's of the quality that it needs to be, that it can turn and then drive value back to them, which can then in turn drive down cost. It can improve efficiencies. It can reduce complexities. And when you do those kind of things, you tend to get a better participation around doing it. But Ryan is right. I mean, in the sense that it's still that there's so many of them that are combating so many other priorities and things, and just simply on the provider side of things, taking care of patients, right? That's what they'll say. Is just like, we have our teams that are either the clinical informaticists or whoever has been designated doing this stuff. They've got other things to do that we need internally, and so we're not sure that's a priority for us. But then when you can show them that the synergies that they put into working with us, it in turn can give them back time or improve efficiencies, drive down costs. They have a tendency to be in, right? And so I want to add though that I can't help to say this, is that I'm very pleased. Much about what you were talking about, Laura, and the brains that are out there that are thinking through how to solve these problems, because most of my career has been on the acute healthcare side of things, right? And so I get it, right? I've seen much of what they have to combat with, and the work that they have to balance, and what do they get out of it, and that kind of thing. But and everybody's pulling at these resources, right? That they want this data. The data is the gold, right? It's the thing that everybody wants, and so anyway, in short, what I do believe that we still have a responsibility as an HDU, HIE, HDU, those of us that are here, is to find these ways that we can help them to, one, instead of saying, hey, your quality of your data, it's horrible, and just drop the mic, right? Instead, we come back and go, let us show you specifically the things that you are missing, and let us, by the way, help you get there. Now you're going to get much better participation. And so we have to keep striving to do that.
Yeah, that's perfect. And I'm just looking at our time, and Scott, you did a perfect wrap up on that, so that we can segue into closing up for today. And I just want to say again, thank you, Ryan. Thank you, Scott. I appreciate your participation and joining me in this conversation about data quality and about the PIQI framework. And, thinking just like what you said, Scott, one thing is saying you have bad data, but the other thing is saying, okay, we're evaluating your data, and this is where you can improve, and this is how you can do it. Clinical architecture has tools to help automate that remediation, which takes the burden off of those agencies who may not have the resources to do that. And so, again, knowledge is power. So knowing what the problem is so that you can fix it down the road. And so if we could go ahead and move on to not the next slide, but the one after that, because I do want to go. Yep, there we go. So let's just real quick close up with a conversation about where we are with the PIQI framework and the PIQI Alliance. The PIQI framework is moving into HL7 ballot, and we are inviting everyone to take a look at and decide if you want to participate, whether you're voting or commenting or just staying in the loop with what is happening with the PIQI framework as a standard. You can use the QR code here on the screen to take you to the HL7 site. And then on the right-hand side, we have a QR code that's going to take you to the PIQI Alliance, where you can also participate if you would like to collaborate, contribute to rubrics, or even help build out use cases specific to clinical, payer, public health needs, et cetera, et cetera. We are doing this as a shared community. That's how we move things along. It's not just theory, it's actual practice. So again, we invite you to join us in this mission of data quality. And again, I just want to say thank you to Civitas for allowing us to share this really exciting and important framework on data quality with everyone. And again, thank you, Ryan and Scott, for joining me. I appreciate your valuable insight. And if you can go ahead and move to the next slide. This has my contact information. So if anybody has additional questions about the PIQI framework or the Pixel Gateway or anything data quality or health information exchange technology related, please reach out to me, and I'd love to talk to you about it. So thank you for being here, and have a great rest of your day.
Thank you all, and thank you so much, Laura, Ryan, and Scott, for this wonderful presentation today. We'll be sure to circulate all the meeting materials with the registrants after the call. And yeah, feel free to reach out to us if you have any questions. And if you want to get in contact with any of our presenters today, we're happy to get you that information. So thanks, everyone, and take care.
Thanks. Bye-bye.